simple episcleritis accounts for how much percentage of cases? Not written here. I'll check out that one for you. Predominantly affects females, has great tendency to recur, and the presentation normally red and discomfort of the eyeball. Clinical signs, redness may be diffuse or sectoral. Sectoral means a certain part, you know, the other part of the conjunctiva looks perfectly okay, because below the conjunctiva, you have the episclera. So a sector of the eyeball shows that redness. Then they refer to that as sectoral. Or diffuse usually the whole area, you know. Attack reaches its peak within 12 hours and then gradually fades. In an unusual case, a person suddenly appears like this. I'll be wondering, has this person been punched? You know. So not all cases of episcleritis, let me put it this way, some cases of episcleritis can mimic cases of trauma, you know, but this is not trauma. As I said, the attack reaches its peak within 12 hours and then gradually fades. Usually moves from one eye to the other eye, or maybe bilateral in both eyes. This is the simple episcleritis. You can see there. Why is it episcleritis? If you move the conjunctiva here, it moves. Okay? It's not conjunctivitis. If it was the conjunctiva, all this other area above here and below would be affected. But you find that in this particular case, you can move this conjunctiva layer above this red area. So it's below the conjunctiva, it's the episclera, it's not conjunctiva. And in terms of clinical assessment, this is what might catch you up if you are not nicely looking. You think, oh, no, this person has got conjunctivitis. They go out with eye drops or whatever, they'll not get better. Please, this episcleritis is below the conjunctiva. So if you touched and moved the conjunctiva, to be moving, that patch is below. So not every red eye should be dismissed as conjunctivitis, please. Treatment of episcleritis, if mild, no treatment, but no patient wants to go to a hospital and come back with no treatment. A weak topical steroid drop 4 times a day for 2 weeks normally is okay. Non-steroidal anti-inflammatory drugs are sometimes required, like flubuprofen, 100 milligrams 3 times for 10 days. You find the whole thing, the inflammation, it goes. This inflammation is not due to any particular infection. So it's not the antibiotics required here. There's no infection. Nodular episcleritis, the other type, tends to affect young females, young ladies, and presentation will be a red eye, typically first noticed on waking up. And people will be wondering, where you went yesterday? Oh, where you? Somewhere. The patient says, oh, we are not fighting. Don't think they are hiding anything. They are telling you the truth sometimes. Over over the next 2 days to 2 to 3 days, the area of redness increases in size and becomes uncontrollable and remains in the same position. If it is, for example, due to infection, that patch will be expanding, isn't it? There will be even evidence of bacterial infection, for example, pus in the inferior fornix. So someone with episcleritis labeled as maybe bacterial conjunctivitis, there should, if it's episcleritis, there should be no pus. If there is pus, it's not episcleritis, then it's a bacterial infection. And because it's not a bacterial infection, you can use steroids just to stop that inflammation. 1 or 2, then what? Installation of 2.5 phenylephrine drops would decongest. That is self-limiting, and treatment same as a simple episcleritis. Otherwise, you can treat it as episcleritis. The other type, the simple, because there is nodular and the simple. Then when you go deeper into the layers of the sclera, then you have this scleritis. Scleritis can be anterior scleritis, non-necrotizing, diffuse, and nodular. Then you've got the necrotizing with inflammation. This is because of the occlusion of blood vessels, and can be granulomatous or surgically induced. Then you can have also necrotizing without inflammation. So necrotizing with inflammation, necrotizing without inflammation, all those are possibilities. Scleromalacia perforans is an example of a necrotizing condition without inflammation. The whole sclera is like thinning away, redness. Posterior scleritis. Which one? Yeah. They didn't see that. Let me see. Is that why that blip came up? Which one? This? Yes. Nodular episcleritis. We saw this. We saw that one.
Chanda.
That nodular part.
Chanda.
You see this. You do a cross section. It's nodular. It's like a nodule. Okay. We want to put it.
Yeah, I was muting them.
This is it. Classification. We've done that, isn't it? Okay. This one, diffuse, non-necrotizing. It is not nodular. John? This one.
This one.
What is it? Huh?
This right.
Yeah, that's the one there. And this is it. Nodular anterior scleritis, non-necrotizing. Non-necrotizing, this one. Why is it non-necrotizing? If it's necrotizing, let's look at the necrotizing now. Is this the one? Necrotizing, aren't you? This is non-necrotizing. What is the picture is what I'm interested in. You can see the pattern, the redness is like normal conjunctiva. But where you go to the necrotizing type is, what is the necrotizing type? See the redness there. completely inflamed, Anterior scleritis, non-necrotizing, is the next one. The incidence of diffuse and nodular scleritis is the same. Large number of those with nodular disease have had an attack of herpes zoster ophthalmicus. I think everyone knows about the zoster. Quite a number of people have been attacked. Presentation, you have insidious onset. It means slowly the disease comes in. There is no sudden onset. Insidious simply means slowly the disease going in. Patient may not be aware. That's insidious onset. Insidious onset of pain followed by increasing redness, tenderness, and the sectoral appearance of the local nodule. That means something growing out there. Clinical features, you have a scleral nodule which is present, which may be single or multiple, and develops in the interpalpebral area. In other words, when you look at the patient, the nodule is not below you will see it within that interpalpebral area. The upper lid and the lower lid, that area we normally see is the interpalpebral area. The area we don't see, you will need to elevate the upper eyelid or lower the lower eyelid to see the sclera. But normally this one is within the interpalpebral area. On slit lamp examination, you've got a light beam is displaced by the scleral nodule. When you put, there is that nodule, it will show because it's elevated. This one is nodular non-necrotizing anterior scleritis. This one is nodular scleritis. You can see that nodule pattern, this elevation. That. Slit beam completely displaced. See, this is the bottom part. This is the elevation of the nodule. That. Clinical signs, over 10% of patients with nodular scleritis will develop necrotizing disease, where the whole retina gets necrotic. Multiple nodules may join together and become confluent. If treatment is started early, superficial necrosis does not occur. The treatment we are talking about here is not antibiotics. You see? Steroids. We're trying to cut out the inflammation. So it's not about giving gentamicin eye drops or what. No, you give and steroid drops to reduce that inflammation. Investigations. Commonest association of scleral inflammation is connective tissue disease. Complications, acute infiltrative stromal keratitis, sclerosing keratitis, it is now going to reach to the cornea. Keratitis is the cornea. Chronic thinning and opacification. Peripheral ulcerative keratitis, where the sclera and the cornea meet, that's the limbus, isn't it? But you may find that there is this, the periphery of the cornea is also affected. This is what they are referring to as peripheral ulcerative keratitis. While on the sclera part, there is inflammation. You can also have that thinning of the cornea, especially in the peripheral area, adjoining this area of scleral inflammation. So you have progressive, what they call melting and ulceration. Melting means thinning. It's not melting like oil. the cornea, the sclera has got its own basic thickness. When they say melting, it means that thickness is getting less and less and less. Uveitis is also a presentation. Glaucoma may be there, or hypotony. Hypotony means reduced pressure of the eyeball. And if there is perforation, you can have also that. Because there is thinning, you can end up with perforation. Anterior necrotizing scleritis with inflammation. This is the necrotizing disease. This is the aggressive form of scleritis, bilateral in 60% of cases. It's not a pleasant idea because here can lead to blindness, you know. Unless treated earlier, it may result in severe visual loss. This is what I'm talking about, blindness. So this you have to treat really aggressive in treatment so that the patient doesn't go blind. The patient will normally come with a gradual onset of pain, which becomes severe and persistent over time. And this person responds poorly to analgesics. They need steroids, not just ordinary analgesics like what is your common one? Aspirin, Panadol. That's not good enough. Clinical signs are variable depending on the three types of necrotizing disease. Vaso-occlusive disease. A vaso-occlusive disease, some of the blood vessels get blocked, and therefore the area where they are supposed to supply thins out. There's no supply there. Isolated patches of scleroedema with overlying non-perfused episclera and conjunctiva. Or you have patches which join together and may proceed to progressive scleronecrosis. Granulomatous disease associated with venous granulomatosis. These are rare diseases. What is that for? This chart. And my businessman enticing me to go to buy. I have no money to buy. I'm a pauper. So these granulomatous disease associated with venous granulomatosis, perforans, nodosa. These are rare diseases. Redness starts adjacent to the limbus, then extends posteriorly within 24 hours. Sclera, episclera, and conjunctiva become edematous and irregularly raised, cause slowly going like that. What they need is anti-inflammatory, anti-steroid or anti-inflammatory, the non-steroid or anti-inflammatory drugs. This is the sclera. You can see necrotic area showing through the white patches, the white area, the outer layer is gone. This is now literally there. Which layer is this now? Choroid. We're now going inward from out episclera, choroid, then you have the retina inside. This is because of occlusion of vessels which supply this area. Vaso-occlusive necrotizing scleritis. Anterior necrotizing scleritis without inflammation. It means the sclera will be thinning, but there is no redness. That's what is referred to as Scleromalacia perforans. Eventually, there is perforation. no redness, but thinning of the sclera, and it may lead to perforation. That is Scleromalacia perforans. It's a type of scleritis without inflammation. So there will be no redness because it's without inflammation. Affects typically elderly females with long-standing rheumatoid arthritis. Presentation, slight non-specific irritation. Pain is absent. There's no inflammation there. And the vision usually unaffected. Why? This is outside, literally we're on the outer side of the eyeball. The vision, if your cornea is okay, light rays will go through. They will go through the pupil. They will go through up to the retina. And so vision may be, usually spared. But people with this patch, the anxiety patch, pain is absent, visually usually unaffected. Clinical signs, necrotic scleral plaques near the limbus without vascular congestion, like the one we saw, this one. This is, it has even been, it has even gone, this one. Scleromalacia. The sclera literally gone, but this is now referred to perforans. You can see there's perforation there. This is below the sclera, that area. It's below the sclera. Near the limbus, this is the cornea part. This is the sclera. Attempt to repair scleral perforation, though it's very difficult. It depends how much, I'm not sure whether a sclera flap would help. Because I haven't seen such cases. Even in UK, I had no chance to see them. But my guess is that it can repair. You can repair temporarily, but since it's a disease, it will recur. It will recur. That was there. Attempt to repair scleral perforation, though it is very difficult. Posterior scleritis, serious and potentially blinding condition. It's bilateral in 35% of cases. Patients with posterior scleritis can go blind extremely rapidly. Why? Because after the sclera, what you have there is choroid, isn't it? From the choroid, you see the retina. Patients will present with eye discomfort or pain. Pain does not correlate to the severity of the orbital inflammation. Might look mild. No? Clinical signs, you have exudative retinal detachment because there is inflammation there, posterior scleritis, posterior part of the eye. So that inflammation, where there is inflammation, there is exudation of fluid. And that can lead to lifting up of the retina, which we refer to as retinal detachment. The inner layer is retina. After the retina, I said there is a choroid. After that, you've got your Episclera and Sclera. So if there is inflammation there, more fluid is being produced and it can lead to retinal detachment. So exudative retinal detachment in 25% of cases, uvule effusion, the fluid in the uvule tissue, characterized by exudative retinal detachment, choroidal folds, usually confined to the posterior pole of the eye, of the block. Subretinal mass may be there, or disc edema may be there, with slight reduction in vision being common. Myositis. Myositis, the muscles which come to anchor on the sclera may be affected. common and gives rise to diplopia because of the pain on eye movement. And tenderness to touch and redness around the muscle insertion. So if there is tenderness and redness on the muscle insertion, it means muscles are the ones which contribute in the moving the eyeball. So there will be pain as the patient is trying to look the other side. As the muscles are called in to move the eyeball, there will be pain because they also get inflamed. Proptosis is usually mild. What is proptosis? Outward protrusion of the eyeball is proptosis. Ultrasound, CT, and MRI is useful in making diagnosis. Because here is because of the edema, you don't know there is edema. You can only confirm when you do a CT scan or magnetic resonance imaging. It will show you. You literally do slides, cross sections, small slices. And you can see that there's a mass here, or no, there's no mass. The muscles are thickened. You can see with these investigations. Differential diagnosis. Possible causes: subretinal mass. When they say subretinal mass, subretinal tumor. Could be a subretinal tumor, choroidal folds, or exudative retinal detachment tends to pull out with fluid below the retina, which is detached. Orbital cellulitis, you remember I was talking about pain on movement of the muscles or movement of the eyeball because of the muscles are inflamed. So orbital cellulitis may be the cause of inflammation of the muscles that move the eyeball. So all that orbital cellulitis, a focus of this infection can be seen or ruled out with the other investigations we put up there. A definitive one may be made. This is the last one. Oh, the last. We have 10 minutes. Let's first hear what the students have to ask. Ladies and gentlemen, any questions or clarifications? This is a time at we are sharing miru. If you are sharing miru, Rich Tenson, your friend will have enough to make a hanshima straw, nicely. Sorry, it will just end up being porridge. So, any questions? No one so far. Yeah, Peter Sana, high level.
Good morning, Doc.
Good morning, my dear. But voice is there. Is that Mr. Pole?
Good morning, Doc.
Yes,
yes, sir. From what we've discussed, we are seeing that these conditions are only common in females, young females. Is it related to some sort of genetics or it's hormonal?
No, let me put it this way. When we say this condition is common in females, that does not mean it can never occur in males. You understand?
Okay. Yes,
That's
sir.
the first. It's like common in males. Yes, common in males doesn't mean it can never occur in females.
Yes, Doc.
That's the first statement I want to. So common in males means more male. I'm not sure whether it's hormonal related. Hormone related, I don't know. I'm not sure about that. But sometimes these diseases, it comes out of an observation. The cases where you get so many, the other center, they are also getting, but without necessarily attaching a cause. If there is a cause, it means maybe some research has been done to determine what, helps that disease to be common in that condition, in those people.
Yes, Doc. Okay, thank you, Doc.
Thank you, my dear. Any other question, ladies and gentlemen? Muleti no kuipushara. When it will be my turn to ask you, it will be for passing or failing. So you ask your questions now. The other point I want to bring to you is, as we discuss these lectures online, take the opportunity when you remain alone to go through and read nicely. I hope we're sending you the recorded versions. You send them, isn't it? Okay. Go through the recorded versions, get a textbook and see. That's the only way you can learn. These lectures are very, very comprehensive. You find in some cases they are really a summary of one or two lectures, chapters in the transcript. Any questions, please? Tomorrow,
just out of topic, not about. Okay. Explain a bit on the difference between.
Good morning, Doc.
Good morning.
Scleritis and conjunctivitis in terms of.
So explain a bit on the difference between episcleritis and conjunctivitis in terms of clinical signs.
Okay. That's from Miriam.
As I was saying, is that Miriam's question? Episclera, the sclera is what the episclera and the actual below that is the actual sclera. On top of the episclera is conjunctiva, which moves. The presentation is completely different. When the conjunctiva is infected, usually it's bacteria, whatever it is, it's the conjunctiva, and you can see, you can even move the conjunctiva. It easily moves. But sclera doesn't move. It's below the conjunctiva. So what are you dealing with? Episclera or conjunctiva? This is a question. The question of a cotton bud, you can move a conjunctiva, but you can't move the episclera and the sclera. They are below the conjunctiva. Apart from that, inflammation of the conjunctiva is either traumatic, there will be that history from the patient. If it's not traumatic, there is something that is caused, bacteria or virus, like that. And if it's bacterial, It's very straightforward because the pus will be there, plenty. Within the conjunctiva, in the phonics, inferior phonics, when you look at the pus, white stuff is there. The viral doesn't give that white stuff, it gives watery discharge. Watery discharge, but there is a history of trauma. So you cannot say this is viral when there was a history of trauma. You know? So that differentiation must be clear cut before you say this is viral, this is the trauma. But there is obviously associated pain. Bacterial conjunctivitis, even with excess exudate or this pus, there is no pain or hardly any pain at all. While traumatic cases will be accompanied by pain. If it's just that watery discharge, okay, maybe viral, there's no pain. Or very mild, if at all, if it's there. Well, the one arising out of a traumatic incident, there will even be history from the patient. When I say trauma, maybe it's a punch by the heavyweight champion of Osaka.
Before we cut, there's another question to say, for those that drink and smoke, we see the redness in the eyes. Is it from the conjunctiva or the sclera?
This is from the conjunctiva.
Then the other one, the sclera is white, but others it has brownish color. What causes that brownish color?
Others is brownish color. In brownish color, if there is one, there is an association with a disease, isn't it? Like what do I mean? The disease is usually allergy. In allergic conjunctivitis, you will see there is a browning of the conjunctiva. The conjunctiva becomes brownish, sort of.